So welcome everyone to our webinar as we officially introduce the recently published RNAO Guideline, Crisis Intervention for Adults Using Trauma-Informed Approaches. There's been a lot of interest in today's webinar. We have had about 150 people sign up from across the country in various different roles in different sectors. So welcome again. We're very pleased that you've taken your time to join us today. So before we get started, I just want to point your attention to the chat box that you'll see on the screen. It's actually in the top right corner of your screen. It says chat in blue. And feel free to type any questions or comments that you may have here throughout our presentation. So you can either send that to the host or presenter, or if you don't mind making your questions public, you can send it to all participants. We'll be having a question and answer period at the end of our webinar today, and we'll try to answer those questions to the best of our ability. If there are questions we're not able to get to because of time, we will respond to those questions in a follow-up email. So first I just want to tell you about the team who is facilitating the webinar today. Myself, my name is Nafsan Nizam, and I was the Guideline Development co-lead alongside Sabrina Morali, who was the other co-lead. Unfortunately, she's not able to join us today. So myself, I am a registered nurse, and my clinical background is in community health nursing and geriatrics. I've worked in several guidelines in terms of the systematic review at RNAO. In this particular guideline, my role involved leading and conducting the systematic review as well as writing the guideline. We also have Kyle Zielman, who you might have heard from earlier today. He was the project coordinator responsible for the development of this guideline. In his role within RNAO, he co-leads the mental health and addiction initiative implementation projects and knowledge transfer activities. He'll also be providing technical support during today's session. So we also have the pleasure of having our two co-chairs of the guideline join us today, and they are Dr. Nancy Poole and Rosanna Yoon. Dr. Nancy Poole is the director for the Center for Excellence for Women's Health. She's involved in a lot of research teams and knowledge exchange projects related to the intersection of women's health, experiences of trauma, and substance use and addiction. In particular, she has a keen interest in the area of trauma-informed practice and has several publications in this area. You'll be hearing from her soon. We also have Rosanna Yoon, and she is a nurse practitioner at the Jean Tweed Center and currently completing her PhD examining trauma-informed care and organizations. She has over 15 years of frontline experience in mental health as well as in addictions. You'll be hearing from her soon as well. We also have Gurjit Tour. She is the evaluation manager at RNAO. She supports nurses, teams within RNAO, and best practice spotlight organizations in Ontario and around the world to build their evaluation capacity. Gurjit collaborated with the panel and the RNAO team to develop new evaluation measures for the crisis guideline that will be practical and meaningful for healthcare organizations. So just a quick overview of our objectives today. Through this webinar, we hope to describe our guideline development process, including the systematic review, just to sort of give you a little bit of context as to how this guideline and recommendations came to be. We'll also be highlighting the main themes that were found in the literature and how this sort of informed key recommendations, and which will also be highlighted. We'll be sharing some areas for future research, as well as describing implementation supports, including evaluation measures to demonstrate the impact of the guideline. I'd like to briefly explain a little bit more about the RNAO. The RNAO is the Registered Nurses Association of Ontario, and we are the professional body representing nurses, nurse practitioners, and nursing students in Ontario. We advocate for healthy public policy, promote excellence in nursing practice, and aim to empower nurses to actively influence and shape decisions that affect the profession and the patients that we serve. Before we move along, we had a quick poll question. We would like to know from listeners today if you have ever used an RNAO guideline before. Okay. So we're just looking at the inputs that have come through, and it looks like a good 60% are familiar with RNAO guidelines and have used them before. So we're hoping that today's webinar gives a little bit more information about our guidelines and provides a little bit more context, and hopefully you can walk away with a bit of new learning in terms of how our guidelines are developed. So on the screen now is RNAO's model for developing, implementing, and evaluating best practice guidelines. I'm showing you this just so you can have an idea that we really have a systematic approach to developing our guidelines and making sure that they get used, get applied in different clinical settings, and we also have ways to evaluate and monitor them. Ultimately, we all want to have a positive impact on the patients that we see, and we want to influence excellence in the care that is provided by nurses and healthcare providers, and ultimately strengthen organizations and systems to support positive outcomes. And this just goes to show we have a systematic and multifaceted approach in doing that. So as there are 3 circles here, I'm going to be talking a little bit more about the guideline development piece, which is the top circle of this diagram in a little bit. So our best practice guideline is a signature component of RNAO. Currently, we have published 40 clinical practice guidelines as well as 12 system and healthy work environment guidelines. In particular to the mental health portfolio, RNAO has published over 12 guidelines in various mental health topics, including but not limited to engaging clients who use substances, assessment and care of adults at risk for suicidal ideation and behaviors, as well as implementing supervised injection services, just to name a few. And all these guidelines are online and can be downloaded for free. I just want to give a big thank you to the expert panel in developing the recent edition of the crisis guideline. It would definitely have not been possible without the lens and support from them. The expert panel volunteered over several months of their time to develop the guideline. The expert panel included a range of perspectives and included people from different professions, settings, and sectors. So we had representation from frontline nursing, medicine, social work, justice systems, so for instance, first responders being police officers, representations from research, students, as well as persons with lived experience, leadership, and management, just to name a few. So here is an outline of the expert panel participants. You can find their specific titles in the beginning of the guideline as well. So this team really spoke to the interdisciplinary nature of the guideline itself and reflected the very different roles that persons experiencing crisis may encounter. Here is a list of the greater RNAO team who I'd like to acknowledge at this point. So the people that are facilitating the webinar are on this team, as well as nursing research associates who had worked on the systematic review. And we also had great input in terms of our internal review of the guideline from our associate director as well as our director. And last but not least, we had 44 stakeholder reviewers from all areas of practice who provided feedback on the guideline prior to the publication. So we would just like to show our gratitude towards them as well. So In terms of the crisis guideline, the purpose of the guideline was really to provide healthcare providers and the interprofessional team with evidence-based, trauma-informed interventions for adults experiencing crisis, as well as strategies to prevent future crises. Our aim was also to promote consistency and excellence in clinical care, health policies, and health education through the application of evidence-informed best practices. A little bit about the scope of the third edition of the guideline. So this guideline actually replaces the 2002 and 2006 version of crisis intervention, and there are some slight changes as well as updates. So first and foremost, our scope really was inclusive to any form of crisis. So whether that be situational, developmental, disaster, or adventitious crisis, we really did not exclude any sort of crisis from our systematic review. For this particular guideline, we also really want to provide guidance on interventions appropriate within the first 4 weeks after a crisis event. So you'll notice that the majority of practice questions are focused on immediate and follow-up actions with the person experiencing crisis within this time frame of 4 weeks. There is some information on interventions provided after 4 weeks or once stabilization occurs. However, this has a lesser emphasis on the guideline, in this guideline. As well, as the title speaks for itself, the backbone for this guideline was really on the principles of trauma-informed practice. So with the emergence of acknowledging trauma in everyday practice, we felt it was essential to have a trauma-informed lens on this guideline to ultimately reframe how care is provided for someone experiencing crisis so that any further harm is avoided. Our co-chairs will speak to these facets of the guidelines today. So we really encourage you to read further details on the scope, intended audience, applicability, guiding frameworks, as well as guiding principles, which are located in the beginning of the guideline from pages 6 to 27. Especially if you are intending to implement the guideline, this background information will be really important to guide your work. We also encourage providers to critically review the recommendations along with its discussion of evidence to consider its applicability to your practice settings. So the guideline is actually organized in terms of the types of recommendations that are outlined. So the guideline has 3 types of recommendations, one being practice recommendations. So these are recommendations that outline what the nurse or members of the interprofessional team needs to do. Then we also have education recommendations, and these outline what the nurse and or interprofessional team needs to know, or strategies on how to best provide those skills for providers. Finally, we have system, organization, and policy recommendations that outline what the organization or system needs to do in order to complement the earlier practice and education recommendations in order to create an evidence-based culture. So this is especially important because we can't just expect nurses to adopt the practice recommendations and expect changes to happen or simply provide education on crisis and trauma-informed practice. We really need to put effort at the various different levels, especially at the organizational level, to really harness that culture. In this guideline, you'll see that we also have new evaluation measures, research gaps, as well as several appendices that can be used at the point of care to support the application of these different recommendations. I'm going to go into a little bit more detail about guideline development for this 3rd edition of the guideline, outlining the 6 major steps. So once we established a purpose and scope of the guideline, we met with our panel of experts to outline the clinical questions that would guide our systematic review. In completing our systematic review, we did set an inclusion and exclusion criteria. We were really interested in gathering peer-reviewed studies that were published between 2011 to 2016. So we were considering the recency of the studies. The studies had to pertain to adults only, so we were looking at studies wherein participants were either 18 and older. The studies had to include interventions that were within nursing scope of practice. So you'll notice that there's no recommendations regarding pharmacological interventions for crisis. articles had to be in English, but we were still inclusive of studies that came from anywhere around the world and in any setting, but really we would have to obviously be able to read them. And these were just some of the major considerations in our inclusion and exclusion criteria. This guided our systematic review of research studies, where we sifted through thousands of studies to find the most relevant articles. This was followed by developing recommendations in-house and going through a voting process with a panel of experts to finalize recommendations. During this voting process, panel members also had the opportunity to develop their own recommendations based on their own practice. And you'll notice that throughout the entire guideline, there was one particular recommendation that was informed by the panel alone. Otherwise, all of the recommendations are informed by evidence. Once we came to a consensus on the recommendations, the guideline was written up with supporting discussions of evidence, after which we went through a rigorous editorial process, seeking feedback from the panel, from external stakeholders, and completing rounds of internal review leading up to the publication of the guideline. So you'll see that in the final guideline, there really is various lens was provided in making sure that everyone's perspective was taken and it was accurate information. So on the screen now is what we call a PRISMA diagram, really going through the steps of the systematic review process we went through and the numbers that we were dealing with in terms of the literature. And this PRISMA diagram really shows the step-by-steps, as well as the final inclusion of articles we had at the end of the day, which was 133. So our systematic review actually involved 4 systematic reviews, amalgamating to a total of 55,000 articles that were screened by 2 reviewers for relevance in 2 different stages. So 1 at title and abstract, and at 2 at full text. As I mentioned, we found 133 articles answering our research questions in regards to practice, education, and system and organization policy. All 133 articles were quality appraised using validated tools to help us determine if an article was high, low, or moderate quality. The quality of the studies used to inform recommendations will be transparent in the discussion of evidence that you will notice in the guideline. So within the 133 articles that we had, there were definitely themes that we were seeing emerge within the literature that guided the recommendations in this guideline. On the screen are a couple of the recommendations that we saw emerge. So first and foremost, there were some articles focused on brief intervention strategies, such as critical incident stress debriefing, as well as some interventions that were particular to specific types of crisis. For instance, post-disaster relief interventions pointed to the use of psychological first aid in both healthcare providers and peer support workers. We also saw the use of telecommunication and technology-based interventions being used within the first 4 weeks of the crisis, whether that be web-based applications or telephone helplines. And these were seen to be helpful as well in the long-term management of stressors. Another major theme was the utilization of interprofessional crisis management teams in community settings, which also mandated the use of interdisciplinary mental health crisis training. In terms of crisis education for the provider, the literature pointed towards the use of teaching and learning methods that were more interactive in nature, while also highlighting the need for mental health training in first responders. The systematic review also captured a substantial amount of qualitative literature covering patient experiences with mental health providers and specific crisis intervention, which has also been highlighted throughout the guideline. Last but not least, articles also highlighted examples of continued long-term supports for the person experiencing crisis, which have been outlined in the appendices of the guideline. Now I just want to give a quick recap of how to read specific recommendations. So if you are familiar with RNAO guidelines, you'll notice that the layout of recommendations are slightly different in this guideline. So each recommendation box will have accompanying information following it. So the green table that you see right here, it outlines the recommendation followed by the trauma-informed principles that pertain to each recommendation, and this will be highlighted for all recommendations. Further, you have level of evidence, which in other words is the type of evidence in terms of the study design that is provided. Information on level of evidence is provided on page 9 of the guideline. Finally, the quality of evidence supporting the recommendation is provided, and in this example, there was 1 study of high quality and 3 of moderate that was used to support this recommendation statement. So we really are trying to be transparent in terms of the types of studies we are using as well as the quality so that you're more informed about where the literature is really coming from. Under each recommendation box, there is a discussion of evidence, which has been further divided into. There's number 1, the summary of evidence, and this is a synthesis of the systematic review findings to support the recommendation, which is then followed by benefits and harms. So these are considerations of further additional benefits or any potential harms that promotes or deters the person's health and well-being. So this can either come from the literature or from panel expertise. We also have values and preferences, and this highlights perspectives from the patient or provider population in regards to the recommendation, and this can also come from the literature or from panel experts. Finally, supporting resources are provided in a table format at the end of the recommendation, providing supports throughout the recommendation. So for instance, in one example, we used practice points to help the nurse or healthcare provider use trigger questions to promote strength-based self-help practices in the person experiencing crisis. The supporting resources we also use to point to other resources which provide a more of a how-to layout of conducting a certain intervention. So for example, crisis intervention, critical incident stress debriefing, we go through the steps of that in the appendices, or we provide a video on how to do that. So overall, we were really trying to highlight the evidence where applicable and provide as many supports as we can to help you carry out the recommendations. So now I'll pass it along to Rosanna Yoon, who is one of the co-chairs of this guideline, to talk a little bit more about trauma-informed practices.
Thanks, Napson. Am I unmuted?
No.
Okay, good. So everyone can hear me. Hello?
Yes, everyone can hear me.
Perfect. Sorry. It's always hard in these webinar-based, right, because I can't see people's faces. Yeah, building on what Napson has been talking about in the evolution of the crisis intervention guidelines, this third rendition really is a complete overhaul and ground-up new guideline when compared to the previous crisis intervention guideline. And the reason is the integration of a trauma-informed lens. So this guideline, I'm very proud and happy to say, is a complete rework. And it's because the founding guiding principles that led the research question that is braided throughout the recommendations and also in the process of engaging stakeholders and the guideline panel were all guided by an acknowledgement and an integration of a trauma-informed approach. And the rationale was very poignant and important. The rationale was based on acknowledgement of the prevalence and impact of trauma in the lives of people. And initially, the discussion began with a very traditional, narrow application of mental health and mental health crisis, but actually a trauma-informed approach embraces the global prevalence of traumatic life experience generally in the general population, and even more so in persons with mental health and substance use experiences. Trauma-informed practice principles provide a framework to guide interventions that are really about being responsive to the person and trying to minimize any risk of re-traumatization through the process of care and to enhance the whole person's sense of safety. So in this guideline, that framework really kind of broadens our usual thinking in clinical practice to embrace safety beyond physical safety, but psychological and emotional safety. Sorry, and one more point. I'm going to go back to the original slide. The slide advanced. Yes, sorry. And then the third bullet I wanted to mention in the application of the trauma-informed practice lens to the guideline is it then extends our discussion of applying that trauma-informed framework when we evaluate our interventions, to evaluate from a trauma-informed lens. To what extent did our interventions also comply with trauma-informed practice principles, and to what extent were they appropriate and effective? Thank you. Next slide. Now, what do we mean by a trauma-informed practice approach and framework? Well, there are core principles of a trauma-informed approach to care, and these are well-established. You know, core resources can be found from SAMHSA, from the Substance Abuse and Mental Health Administration in the U.S., but also in Canada, led by Nancy Poole, who's on the call with us from the BC Centre for Excellence in Women's Health, but also in the sector. So now we are really at a time where as a practicing clinician, I'm seeing acknowledgement in our healthcare sector, in nursing, in social work, across disciplines, even from our guideline panel members who work in corrections and policing, an appreciation and acknowledgement that trauma-informed practice principles are important. And what are these principles? A core principle is safety, which basically means that we prioritize maintaining and enhancing person safety. And by safety, we mean beyond physical safety, psychological, emotional, physical, whole person safety. Second very important principle of trauma-informed approaches to practice is trustworthiness and transparency. So, to what extent do our interventions maintain trust and build trust, and to what extent do we engage people in a transparent way? The third principle is collaboration and mutuality, which is very foundational to even nursing practice in our therapeutic relationships, but also foundational in trauma-informed practice approach in that collaborating with someone in a mutually power-sharing, equivalent, respectful way is essential to the trauma-informed approach. Empowerment, voice, and choice is another principle of trauma-informed practices that emphasizes interventions and ways of working with people that is based on strengths and bringing out, choice and self-efficacy and, power sharing. So not empowerment, but really the idea is power sharing, bringing the power of the person to the forefront. And another foundational principles of a trauma-informed approach to practice is peer support. So not just lip service, let's have someone with lived experience, give their, survey input, but really meaningful and real, true integration of peer support, which comes from a valuing of the unique contribution of people with lived experience and valuing that contribution and making efforts to integrate that through the general ways of working. And then the last two, the peer support and the cultural, historical, gender issues principles are newer principles that have been added by SAMHSA to trauma-informed practice principles. But the cultural, historical, and gender issues really highlights a need to be responsive to of biases related to race, gender inequality, historical, and issues of oppression that lie in the background. And so this resonates with, you know, communities that have been institutionalized, communities that have intergenerational trauma, and we have a lens and an openness to put that into the forefront. So these core principles form the backbone of a trauma-informed approach.
Thank you, Rosie. I will now pass it along to Nancy to go over, give a high-level overview of the recommendation.
Hi. I guess it's flipped back to, can you just put it back one for a sec? And forward one. There we are. So, whoops, we keep losing it. There's the overview. Thanks. So you'll see that we have 15 recommendations in total. As Jen said, that, you know, in these 3 areas of practice, education, and systemic level work. And you can see within each of those, we were answering these various research questions. In the practice area, thinking about what are effective and trauma-informed interventions that healthcare providers can utilize with adults who are currently experiencing crisis. And also the second one related to mitigating and preventing future crises in adults. And then in the education level, just, you know, obvious kind of what content and educational strategies are necessary. And on the system level, and this is so important in trauma-informed practice, and as was said overall, that, you know, it can't, this work cannot fall only on the shoulders of the individual provider, but very much needs to be built into organizational and system level ways of working in collaboration. So we looked at best practices in that area as well. I'm just going to give a couple examples of the practice recommendations, and alongside you can see how we've tried to think also about how these principles of trauma-informed practice are being woven in and aligned with the evidence. In the first one, the recommendation is about supporting people experiencing a crisis to meaningfully and safely engage in critical incident stress debriefing process in that immediate post-crisis period. And, you know, I think what's really interesting about critical incident stress debriefing is it's both old and new. I mean, it has been with us for many years, and evidence continues to show us that it can be easily implemented and cost-effective for reducing distress and the perception of stress. And the other thing that's so interesting about it, I think, is that it's also flexible. It can be done with individuals and with groups. So you'll see in the literature, I mean, in the guideline, a table that talks about some of the elements of it. And you'll also see in that area about values and preferences is that people, both people receiving this kind of debriefing and doing it, did feel very supportive of it as a method, and clearly one which builds on this idea of empowerment and strength and safety and choice and all of those pieces. So that's one of the practice recommendations. The next one below it is about creating crisis plans in collaboration with persons experiencing crises, again using a strength-based approach. And I think this is so critical. Rosie talked really well about it as an overall principle. We did find studies that emphasize the importance of working collaboratively with persons to co-create crisis plans and to be involved in goal setting. Because it empowers people and allows their real active engagement. And, you know, those of you who may have worked in the violence field overall really understand, you know, the importance of safety and crisis plans both before and after crisis incidents. And I think, you know, this is a great piece to be able to work into our immediate crisis responses. Lots in that area around studies around the values and preferences of people who have been involved in actively creating goal setting and planning and crisis plans with providers. So there's quite a bit in there that I think is of real interest to people, and lots of recommendations of where else to go to find examples of how people have implemented and co-developed crisis plans. And the third one I picked from the many practice recommendations we had was related to the peer support trauma-informed practice principle, and is really about engaging peers trained in evidence-based approaches such as psychological first aid to provide comfort and safety to persons experiencing crises. And, you know, I work in the substance use field and have really seen the role of peer support workers in the safe injection sites, et cetera, that really, alongside nurses and others, have been really excellent supports in that. So while, you know, the evidence around psychological first aid is not as strong as it might be, we still felt it was a really good example of how to bring in this idea of evidence and principles of trauma-informed practice. So I'll turn it over to you.
Thank you, Nancy, for highlighting some of the key practice recommendations and linking it to trauma-informed principles. I'll be moving along and speaking to the education recommendations that emerged from the literature. So there were two key education recommendations. The first recommendation was in regards to incorporating interactive learning opportunities on trauma-informed approaches and support for persons experiencing crisis into curricula for all entry-level nursing and healthcare programs. So the evidence was really demonstrating that when healthcare students were taught through non-traditional methods such as discussion, videos, patient simulation, use of reflection, they really showed improvements in knowledge and also demonstrated that this was their preference in the learning style. So as a panel, we recognize the need for education around crisis and trauma-informed practice at the undergraduate level, introducing the concepts and skills early on. Another recommendation was in regards to all staff within an organization engaging in education, with crisis education being more specific to healthcare providers, but trauma-informed approaches, on the other hand, being more relevant to all staff within an organization. So that being people who are outside of the healthcare professional role, so whether that be security, reception, et cetera. And it's really recognized that it is important to generate trauma awareness through education across healthcare services among all members of the interprofessional team who are directly or indirectly involved with persons who have experienced crisis. So proper precaution is taken to avoid inadvertently trigger negative emotions associated with trauma. Overall, research demonstrated that these continuing education opportunities provided in-house had positive outcomes on staff knowledge, skill, confidence, and attitude. So the next recommendation sort of ties in with a system-level recommendation, but also has facets of literature coming from education-focused articles. So training and education literature was apparent, especially in the literature pertaining to police officers, in particular as first responders. So within this evidence, we actually advocated for widespread education among police agencies through an organization system-level policy recommendation. So as you can see, there's two components to this recommendation, one being police agencies integrate comprehensive crisis training to A, enhance police officers' interaction with persons experiencing crisis. So the literature is really pointing towards crisis intervention training for police, demonstrating positive impact on knowledge improvement of mental illness and treatment among police officers, as well as helping to decrease stigma towards persons living with mental illness, improving one's self-efficacy for interacting with individuals experiencing psychosis or suicidal ideation, as well as improving de-escalation skills and referral decisions. Overall, it was found that police officers who had received crisis intervention training resolved encounters with less use of force. And we really felt that for this recommendation, the trauma-informed principle of safety was very apparent. The second component of the recommendation was to integrate comprehensive crisis training for police to encourage police officers to make informed decisions about helping persons access appropriate services. So evidence was demonstrating that officers who received crisis intervention training were more likely to refer persons to mental health services or to take them to a treatment facility for a psychiatric evaluation. They were also less likely to execute an arrest, and they reported knowing more options when deciding the outcome of a crisis assessment in the community. I'm going to pass it along to Nancy again to speak to some of the other examples of system-level recommendations that came forth from the literature.
Thanks very much. Yeah, I think this part is so critical to nursing practice, that organizations, the 4.1 recommendation, that organizations identify and embed trauma-informed approaches within their policies and procedures to support a framework to the approach to crisis intervention, and also to create a really safe and supportive work environment for healthcare providers. And I think it's really, this is a really important one overall in terms of us thinking before crises about how to have a framework for a response that really has, checked the boxes around how the organization itself works in a trauma-informed way, and particularly helps workers with secondary trauma, the experiences of that, and their own self-care and wellness in the context of this work. Really important piece. And the second one I've brought up here, recommendation 4.3, is about collaboration at the system level. We talked about collaboration at the level of the between the provider and the person experiencing the crisis, and here we're really talking about the importance of that collaboration across systems of care, and really thinking about an approach where people experiencing crisis experience trauma-informed approaches and collaborative approaches from every person they run into in the context of that crisis. And we were also very much thinking about how do we link up some of these resources that we didn't cover as examples of the practice recommendations, but which are within the practice recommendations. The people who are doing mobile crisis, the people who are doing outreach, and the people who are doing telephone triage and helplines, and really making it a system that works well together. So lots to think about in terms of these recommendations, and I think really important ones for administrators as well as those who are working in direct service with patients and clients. Now, you know, we did include a couple of pages of thoughts about research gaps, and here are, you know, 3 examples. There are many research gaps here. You know, we found overall that we found way more literature around trauma-informed approaches to people who'd experienced crisis for the long term, many more studies in that area than we did in studies for the short-term crisis time frame that this document covers. And, you know, I think it's clear that that's likely partially due to the fact that it's hard to study those crisis moments. But, you know, I think really lots more needs to be done so that we can be confident in this work. And hopefully this guideline will encourage lots more thinking and action in this area. But that idea of how do we do assessment immediately after a crisis event, how do we look at the needs and preferences of diverse populations, including Indigenous populations and also different gender groups, and how do we actually think about to inform the system level recommendations as we go forth, to really think about the systemic factors that contribute to crises and think about how we can be preventing those and working collaboratively and studying what those factors are and how we can best mitigate them. There are many, many other research gaps we noted on these 2 pages. So love to be involved with people who are interested in following up on those.
Thank you, Nancy. I will now turn it over to Gurji, our evaluation manager, to give some insight about guideline evaluation as it pertains to this guideline.
Thank you, Nathan. Pages 57 to 60 of the guideline address guideline evaluation, and this aspect of the guideline is really, really important to look at in terms of how you're going to evaluate the success of guideline implementation when you do pick up the guideline. So what we've done here, we've created 2 tables. The first table looks at your overall measures of success, what traditionally you may look at as key outcome measures. And when we looked at the literature and what was available in terms of measurement on this topic, it was a bit of a challenge. There isn't as much of a focus on crisis in measurement in our healthcare system. And so there are a few measures we were able to identify that are reported in different places such as CIHI and RAI. So these are, CIHI is our Canadian Institute for Health Information, where a lot of our healthcare data resides. And InterRAI is an instrument used by organizations in being able to measure specific areas. So as you can see in Table 18 of on the slide, we have a number of measures looking at things like percentage of persons reporting crisis in the last 30 days, percentage of persons reporting more than 14 days of crisis in the last 30 days. And although these focus primarily on psychological and mental distress, they can be adapted to be used in different types of crisis as this guideline provides recommendations for. So along with that, we also have some more novel measures that we're introducing. And just to keep in mind, the measures that we've put into this guideline have, the new ones at least, are measures that we're proposing. They are not measures that are validated as such. However, they provide a guidance for anyone picking up the guideline and being able to support
E&D, west corridor, south exit door.
Someone needs to put their phone on mute.
That we're on mute. Are we on mute?
Okay, thank you. And so some of these measures provide a guidance for those picking up the guideline and hoping to implement the guideline in their settings to be able to be supported by the table provided here to give you a guidance on overall success measures. And on the second table on page 58 of the guidelines, so table 19, that gives you more of your implementation-specific measures, so measures that are aligned with specific recommendations from the guideline. Again, none of these are addressed by existing performance measures within the healthcare system, as these are specific to the guideline recommendations themselves. So again, these provide you an opportunity to start thinking about how you may be able to evaluate the implementation of the guidelines. So, for example, for recommendation 1.1, we have a measure percentage of persons in crisis who receive brief intervention as part of routine care. Now, you can see that these measures are quite broad. They're not as specific because the purpose of these measures is to provide you guidance to be able to adapt to your setting when you do implement the guideline and be able to support you in the evaluation and being able to demonstrate impact. And for those that are BPSOs, or best practice spotlight organizations, they have an opportunity to then use specific measures from our nursing quality indicators for reporting and evaluation data system to be able to evaluate guideline implementation. That is separate from this, what's provided in the guideline. However, if you do follow some of our other guidelines, clinical topics, we do provide an indication of which of these indicators highlighted in the table are also provided in the inquired data system. Thank you.
Thank you, Gurjeet. So we have a few more minutes left in this webinar, so I'll be describing a little bit more about our implementation resources to kind of help wrap everything up. So you're probably wondering what you can do next. How can you move forward and implement this guideline? So one of the strengths of the RNAO is that we have a systematic approach for supporting the implementation of best practice guidelines. We provide supports to individuals, organizations, and we also support system-level change. So one example being the best practice long-term care program, which is Ontario-wide. So that's at the system level. So you can see on the wheel that all kinds of ways that we support the implementation and sustainability of guidelines. So if you're an individual who wants to learn more, you can attend our various workshops, conferences, attend more webinars like this. We also support advanced practice fellowships, provide e-learning courses, as well as Gurjeet mentioned, we support best practice organizations. So overall, we offer a lot of support for you with several resources. So here are a couple of implementation resources that are specific to this guideline that you can either access now or in the near future. So right now, you can actually access our health education fact sheet entitled Understanding Crisis, a fact sheet for adults experiencing crisis. And this fact sheet really helps people understand what a crisis is, how to identify it, and provide some tips and tools on how to manage crisis triggers. So this is available for download, and I hope you find it useful for your education purposes. We also have a BPG app, which is free for download on your smartphone, and you can access key elements of practice recommendations and appendices from your smartphone while you are working at the front line. So that's also a free resource and includes recommendations of guidelines published to date. However, the inclusion of recommendations from this crisis guideline hasn't been uploaded into the app yet, and we anticipate this being completed by the summer. As well, nursing order sets will be available in the near future as well, and nursing order sets really just make it easier to translate evidence into nursing practice by providing clear, concise, actionable, evidence-based intervention statements that can be readily incorporated into electronic health or medical records, but they also may be used in paper-based or hybrid order entry systems. So here are some suggested next steps if you are interested in moving forth using this guideline. First and foremost, we really encourage you that in collaboration with the interprofessional team at your organization, you come together and read the guideline and identify what may apply to your setting, so what is appropriate. We also recommend you conduct a gap analysis, and what that is that it lists the recommendations that you consider at your current practice and assess whether right now there is a big gap, small gap, or no gap. And this gap analysis really allows you to reflect on where you want to focus your energies and improving your care toward, improving your efforts toward evidence-based practice. So this gap analysis template is also available for download on our site. You can also become a best practice champion. So we have several champion workshops throughout the year that teaches you strategies to support best practices in your workplace. And this is more generic to all of our best practice guidelines. You can also download our free toolkit, Implementation of Best Practice Guidelines, 2nd edition. And this really is an implementation science resource that's also free, and it walks you through the steps for implementing and sustaining best practices. So before I move along, I just have another quick poll to gauge whether or not you would see yourself using this guideline or implementation resources within your own practice. Okay. But yeah, okay, so that's great. A lot of people are replying yes. Over 50% of you have mentioned that you have voted that you will be using this guideline and the implementation resources, and we're really happy to hear that. And finally, I just want to speak a little bit about the Mental Health and Addictions Initiative, which is more implementation resources that is more specific to mental health and addictions topics. So as we know, crisis is really multifaceted in that factors are widespread. And so if you're interested in other mental health and addiction topics, we really encourage you to access our archived eLearn module. So we have modules on the Addiction Learning Series, Engaging Clients with Substance Use Disorder, Engaging Youth Who Use Substances. We also have an educator toolkit, so recently published Nurse Educator Mental Health and Addiction Resource, which is a guide on integrating mental health and addictions into the undergraduate nursing curriculum. We also host full-day champions workshop that is more specific to substance use. Again, you can find more information on these resources at www.rnao.ca/mental health. So I've noticed we've come to the end of our webinar. Unfortunately, we don't have time to take, I think there was actually, yes, there was one question that we will be addressing right now, but if you have further questions, we are more than happy to email you with a follow-up. So we have a question asking, is the recommendation around peer support related to involving peers in the crisis plan development? So in terms of the crisis planning development literature, there wasn't specific literature suggesting that peer support is involved in crisis plan development, but I think there is a general consensus with our panel that, yes, you know, peer support are more than capable in helping someone to to create a crisis plan. Nancy and Rosie, I don't know if you have any other comments about that.
I think Nancy spoke to, when she was talking about some articles speaking to the importance of peer support, but in practice we know I can talk locally about Toronto, but in Toronto we have mental health peer support workers working out of at least 2 emerges in the GTA for mental health and addictions, working with people in that crisis moment in emerge, which has shown to have great clinical value. And also, this best practice guideline development process reviewed current literature, which speaks to the gap. I think the key value of this guideline is now it will inform future and present research to look into the role of peer support in immediate crisis event. The fact that I think that's an important gap that this guideline development process identified. But in practice and in terms of trauma-informed practice, and also not only that, but in the mental health and addiction sector, we know the value of peer support. And also electronic connecting. Now we have the big white wall for connecting on mobile devices with peers, and it's shown to have great positive impacts for people with mental health and addictions.
Yeah, and I think overall that's so true, Rosie. Specifically in the development of crisis plans, I think would depend on setting to setting and the preferences of the patients you're working with about whether they want a peer support person involved or not, et cetera. So it's always about choice and voice, and feelings of safety. In some cases, they may be the better person to be the people supporting that early on, and that might be something built into a certain service where peers do help people do that as a matter of course when they enter the service. It would really depend on the context, I think. But I think the key thing is that the peer support workers have good training.
All right. Thank you, Nancy and Rosie, for addressing that question with your knowledge and expertise. So I think that's the only questions that we have today. The other ones are in terms of our presentation. Yes, it will be archived. You can access the full presentation with the recorded information online, and the slides will be shared, which Kyle will speak to in a bit. But I just want to wrap up and thank everyone for their participation and listening in today. A lot of work went into this, and we're really happy to know that you will be going out and using this guideline and implementing into your organizations, and hopefully you will spread the word because at the end of the day we really want to improve outcomes for patients. So thank you.
Yeah, thanks, Nathan, and thanks so much, Rosie and Nancy. As Nathan had mentioned, I will be sending out a follow-up email. The follow-up email will include a link to an evaluation. We really appreciate any feedback that you can provide us just so that we can enhance these webinars for future. Once you submit the evaluation, you will be able to download a PDF or a digital version of a certificate of participation if you need to share that with your employer for any continuing education hours. I'll also include as an attachment a PDF of the slides that you'll be able to share. So again, thanks so much to everyone for participating today, and if you have some follow-up questions, Natsun's email is included in one of the last slides, as well as my contact information most of you already have, so feel free to send us an email at any time. And have a wonderful afternoon. Thank you.
Thanks, Carl.
Thank you.